We are going to. All right, guys. So today I'm excited because we're going to be talking about some NCLEX study tips for you guys so that you are able to answer some questions. My name is Damaris. I am the CEO, co-owner, and one of the tutors of EdMe Nursing Tutoring, a family-owned business. And our heart is to empower, encourage, and really help nursing students be the world changers they were always destined to be. So for those of you who are on YouTube, I am staring at my phone for Instagram. So forgive me, I'm going to be going back and forth because I want you guys to get my undivided attention and not feel neglected. So a little bit about me. I do have a master's in nursing education. I decided to go for that because I realized my passion and heart to educate the next generation of nurses. And so I went back and got my master's in nursing education, and I've been a nurse since 2017. So I am proud to be a nurse. I always wanted to be a nurse, but my family has a teaching calling on their life. So I somehow ended up in education anyway, but at least it's in my passion. I am also a certified faith community nurse as well. And I also did get my bachelor's as well back in 2016. And so my husband and I decided to start this business because we've been tutoring and mentoring people since we were in nursing school. We met in nursing school. And so we are nursing school sweethearts, and we got married shortly after we graduated from nursing school. And we had a child. Love my son, and he's a blessing. And my husband is a student CRNA. So he is going to be getting his doctorate in nurse anesthesiology. And so for those of you who are interested, he can help you out with that if you're interested in being mentored into the CRNA profession, or if you are looking to go into CRNA school, or you've already been accepted and you're just waiting to start, he can help you in that direction. I am not in that direction. But anyway, so let's jump right into it. So I'm just going to give you guys some tips on answering psych questions. Some people I notice have some difficulty in that, and I just wanted to shed some educational tips for you guys to keep in mind. So I hope you have a notebook and a notepad. So the first thing is know your defense mechanisms. There are a lot, but know the main 17 that they have. There's 12 to 17 that we really focus on in nursing, and that NCLEX can ask you. And so definitely go over that. You have sublimation, you have repression, regression, you have suppression, you have projection. So there's so many of them. Go into detail about them, study them, because they will ask you some questions concerning that, and know what it looks like. All right. So sometimes NCLEX will give you a question and ask you which of the defense mechanisms is the patient experiencing. And so they want you to know that. Or what they'll do is they'll tell you that the patient's experiencing one of the defense mechanisms, and they ask you as a nurse, which of the following is the defense mechanism being explained in the question. All right. So make sure you guys go into depth about that. The other thing I want to touch on is delirium tremens, which you usually see this in alcohol withdrawal patients. This we call DTs. And you will see this as a bedside nurse when you start practicing. You'll see this as a bedside nurse, especially if you are working on a regular floor or in the ICU, and even in the ER. For those of you who are more in the outpatient settings, you may see this in a detox facility, rehab facility, but for the most part, you do see this as a bedside nurse, and you may get those types of patients. So delirium tremens, we try to prevent this from happening because the patient can experience a lot of different symptoms. And some of those symptoms can be life-threatening. So some early signs there's a few early signs of delirium tremens, and that's typically when the patient sometimes comes in, is when they have those early signs of delirium tremens. So the physiological things that they'll exhibit are restlessness, and not physiological, I'm sorry, the psychological that they'll experience is restlessness and confusion. All right. And then some of the physiological that they'll experience is tachycardia, tachypnea. They'll experience like excessive diaphoresis. They're sweating like crazy. They'll have tremors, and they're extremely irritable. All right. They are very irritable at that point because they're withdrawing. Their body is not responding well to that withdrawal. The body's craving it. And now they're having physical manifestations. Some late signs are usually mental, so also psychological, but they're more exacerbated. So things like hallucinations, things like paranoia and seizures. So when you have a patient who starts, with some like restlessness and confusion, that's your sign or your hint that you need to start getting on it fast before they go into full-blown hallucination, paranoia, and seizures. If you start seeing those hallucinations, paranoia, and seizures in your patients, they're already in a late stage of the DTs, which is not a good thing. All right. So NCLEX wants you to know the difference between the early signs and the late signs of DTs and what to do concerning it. Now you might be wondering, well, what are the reasons for why they're experiencing these things? Well, the biggest thing is that most alcoholics who drink excessively, especially throughout the day, those are the ones that typically experience DTs. It's not like, a hangover where you drink too much in one night and then the next day you wake up and you're like hungover or super drunk, right? That's not DTs. DTs is chronic alcohol consumption, meaning you drink a large amount every day, and it's like pretty much your breakfast, lunch, and dinner and snack. All right. So those are the people that usually come in with DTs. So if someone's having DTs, they're a chronic alcoholic. And when they are stable, you need to determine what is their consumption amount, right? And that's going to help you determine your course of action, especially when they need to go for rehab, and they need to treat themselves when they go home. All right. So one of the biggest causes is vitamin deficiency, right? So not only are you eating enough, right? You're not eating enough food, because the alcohol kind of stunts your hunger for the most part, but you're not absorbing the nutrients and vitamins that you need that are crucial for your health. So one of those big vitamins that they lack is thiamine, and thiamine has a direct correlation to our neurological function. So that's why they start to have all these neurological symptoms of DTs, because they're lacking thiamine. So what we give them is what we call a banana bag, right? Which we call it a banana bag because it's yellow, right? And that is full of nutrients and vitamins, and especially it's high in thiamine. And that's to help prevent those neurological symptoms from progressing, and help to replace and replenish those depleted vitamins. So those are one of the biggest things we do when they come in. Another thing is that we provide them IV hydration. They are very dehydrated. Alcohol causes dehydration, especially large amounts of it. And that dehydration can cause a lot of other physiological symptoms. So we try to provide hydration. We also give them sedatives, especially when we usually initiate a CWA protocol, which every facility has their own CWA protocol. But the main thing is that it asks you a list of questions. So make sure you know the CWA protocol for NCLEX. It asks you a list of questions, right, that you have to fill out for your patient. And it tells you whether or not the patient is, a high risk for, seizures, or if their alcohol withdrawal is severe, moderate, or low. And so a lot of times that CWA protocol also tells you what to provide that patient depending on what their score is. And a lot of times sometimes depending on the score, they require a sedative, usually a benzo, to help calm them down. And we also give that to them when they're getting extremely agitated or when they start having seizures. But sometimes we initiate it earlier on, but a sedative is what we usually give these patients to help keep them calm and calm their neurological function so that they don't go into a hyper vigilant state in their, neurologically. And also seizure precaution. Putting them on seizure precaution is really important with your DT patient, because they, at any point in time, even if you are treating the early signs, they can still progress to a late sign, right? They can still progress to the late stages of DT. So you want to make sure that you have them on seizure precaution ahead of time. So have all of those things at the bedside, the bed rails padded, have the suction nearby already set up. to make sure that the patient doesn't aspirate if they go into a seizure, and just make sure that you have that everything is safe for that patient if they start to seize. And the other biggest thing is, NCLEX might ask you, is things like keeping them in a calm environment. So, reduce the amount of visitors, reduce the noise frequency or amount, right? Lower the light, dim the light, don't bother them too much or overstimulate them or ask them questions that might irritate them even more, right? Try to cluster your care as much as you can so that you can leave them alone as much as you can, because they are irritable and their brain is already overstimulated from the lack of withdrawal. So you want to make sure that you try to decrease the amount of stimulus as much as possible with these patients. All right. Hey, bestie, thanks for joining. So, so the other thing that you want to look out for in your patients with delirium tremens is you want to make sure that you're looking out for signs of a myocardial infarction. You want to make sure you're looking out for some vascular collapse, aspiration, especially if they're having a seizure, embolism, because their blood is coagulated and they are dehydrated. So you want to make sure that they're not developing clots, and those clots, we don't want them to break off and go into the lungs or cause a stroke or a heart attack. And then you also want to make sure you manage their electrolyte imbalance. The reason being is because of these patients that drink chronically, right? Like I was saying earlier, they're not getting the amount of nutrients and vitamins and hydration that they need. And therefore that causes their electrolytes to be imbalanced. So they start to have low sodium, low potassium, low magnesium. A lot of their electrolytes are low, and that can further exacerbate their electrolyte imbalance. And that can cause a lot of what those symptoms like MIs and vascular collapse and seizures, etc. So therefore, when you have all that happening, you got to make sure that you're replenishing those vitamins, those minerals, and those electrolytes and their vascular hydration. All right. So we want to make sure that we are helping our patients as much as possible during that time of alcohol withdrawal. All right. So a big tip, NCLEX may or may not ask you this, but in case they do, you'll remember me. Wernicke-Korsakoff, okay? Wernicke-Korsakoff syndrome is usually seen in our DT patients because of that lack of thiamine. So when you have a deficiency in thiamine from drinking alcohol chronically, thiamine helps with neurological function. So if you're not getting enough thiamine, then your brain is not functioning properly. Hence why you have a lot of those issues with those neurological symptoms, such as hallucinations, paranoia, and seizures. So when that's happening and they're experiencing that, the NCLEX wants to see, do you know what Wernicke-Korsakoff syndrome is, right? Do you know what it is, and do you know why? So thiamine, low thiamine, which results in the damage of your neurological function and can also result in death ultimately. And that's the reason why we want to provide them with that banana bag. We want to replenish their electrolytes. We want to give them IV hydration, because we want to prevent that neurological damage, which can be permanent if not reversed sooner. And we want to make sure that we prevent death. All right. So like that MI, the embolism, etc. All right, so that's with DT's patients. Moving on to delusions and hallucinations. So a lot of people don't know the difference between a delusion and a hallucination. And I'm not gonna lie to you, when I was in nursing school, I didn't know the difference either. I'm just being real, right? So a delusion is a concept, idea, or a strongly held belief about something that is not reality, okay? For example, I'm Jesus, right? I'm not Jesus, but someone who's delusional believes they are. Or I work for the FBI. They don't work for the FBI, right? So those kinds of delusions, or people who sometimes they'll believe that they are somebody, that they see something, or that something's happening, or that they have a belief about some kind of conspiracy theory that's not real. Now, side note, depending on the conspiracy theory, they may very well be right, but they obsess over it, right? So as far as delusions, right? It's a thought pattern, okay? A thought pattern that they have that they believe in, okay? And usually you see this in patients who have who have psychotic disorder. So things like schizophrenia, they present with delusions about something. So for example, you guys learned in nursing school about paranoid schizophrenia, right? So they believe that somebody's out to kill them, even though no one's out to kill them, right? So they'll believe that the FBI is out to kill me, or you're trying to poison me with this food. That's a complete, that's not reality. No one's trying to poison them. No one's trying to kill them. No one's following them. No one's doing anything. But because they hold so strong to that belief system, it's a delusion. So a delusion is a reality about their reality, but it's not real. It's a thought about something that's real to them, but it's not real to the majority of the population. All right. So that's the difference between the two. Now, hallucinations they involve the five senses. So touch, feel, right? I mean, touch and feel, same thing. Touch, smell, taste, right? Vision and hearing. Okay. So a lot of times they start to have this stimulation of their five senses, or one of their five senses, and it's not real. Okay. So for example, do you see that gnome on the floor that's trying to kill me? What gnome, right? Oh, I can see that, you know, do you see that dog that's barking at me? What dog, right? So, or do you hear that? Do you hear that voice? I hear a voice that's really angry with me. It's telling me to walk into the street and kill myself, right? So they start to hear things, see things, they start to smell things, feel things that are not there. So it stimulates the five senses, but it's not real, okay? So sometimes this can be caused by psychological disorders, so like mental health, you know, psychiatric disorders, but it could also be caused by pathological disorders. So sometimes you may have a brain tumor that stimulates a hallucination, or you may have an imbalance in your diet from something, or a neurotransmitter that's not, you know, you're not producing enough of, or you're producing too much of, but it's because of some kind of pathological or physiological reason for that hallucination. So don't assume that because someone's hallucinating, the first thing you want to rule out is a physiological reason. Okay. Once the physiological reason is ruled out, then you can then determine if it's a psychiatric reason. Okay. But when NCLEX is asking you psychiatric questions, they usually ask you in relation to a psychiatric disorder. Okay. So one tip about delusions is that you want to make sure that the client, right, is that you're not playing into it, you're not challenging it. That goes for hallucinations as well. So as a nurse, when NCLEX throws you a question about a patient who's being delusional or hallucinating, you don't challenge it, but you do address it, especially if they're hallucinating and they're saying that the voice is very angry with them, for example. One of the things you have to do as a nurse is determine, is that voice telling the patient to kill themselves or to kill someone else, or to harm themselves or to harm someone else? So you do have to ask the question, what are the voices telling you? But once the patient answers it and you determine whether it's harmful or non-harmful, you then redirect them, okay? So you bring them back to reality. You don't challenge it, but you bring it back to reality. So you say, okay, I know that you think that you hear this voice. However, I'm not hearing the voice, right? So you don't challenge them in saying, no, what you're hearing is wrong. There's nothing there. You're crazy. Stop that. Calm down. Like, you don't do that. What you say is, I understand that it feels real to you, but I don't see it, or I don't hear it, or I don't smell it, right? So you tell them reality. You reintroduce them to reality, all right? Bring them back to reality, all right? And then you also redirect them as well. Now, for hallucinating patients, if a patient's hallucinating, one of the things that NCLEX likes to ask you is, how did they manage the voices in the past, if they've had this before? So let's say back in their past, they used to hallucinate a lot, and now it's under control, and then all of a sudden, boom, years later, it starts triggering again. One of the things you do as a nurse is ask them what worked before. How did you manage that voice before? All right. So when that happens, you want to determine, again, what are the voices saying? And then you want to provide that safety for that patient. You don't challenge them. You don't tell them they're crazy. You don't tell them what they're, no, you're wrong. Stop that. You say to them, listen, I hear you. I understand what you're saying. However, that's not the reality. right? So you want to acknowledge their feelings, but you don't challenge or you don't play into the delusion or hallucination. All right. You never do that. Okay. So you explain reality to them, but you don't challenge it and you don't argue it and you don't play into it. All right. Just redirect them to reality. All right. Now, bipolar disorder. Okay. So some tips on that. When a patient is in the manic phase, because remember, bipolar is two different feelings, right? So you're either super manic, right? Where you're just like all over the place, or you're super depressed. Okay. And they have this fluctuation all the time, right? So when a patient is actively in the manic phase of bipolar, your job as a nurse is to decrease stimuli. Okay. You want to decrease stimuli. Then you also want to redirect them to physical activities, but not competitive ones. Okay. So because that competitive activity will cause them to become more agitated, it will cause them to become more irritated, and it can cause them to lash out on their competition. So you avoid activities like, like a race or, card games or whatever. And what you do instead is you do things like exercise, right? Or you do things like dance, right? So you direct them to physically active activities to get their energy out, right? But you don't put them in anything competitive or aggressive, okay? Because it will shoot them off, all right? Now, one of the medications that a lot of people are not familiar with is valproic acid, okay? We know about the other medications like lithium and all that stuff, but valproic acid is a question that NCLEX can give you. So when a patient is diagnosed with bipolar, sometimes they put them on valproic acid, and valproic acid helps to either prevent seizures or treat manic phase bipolar. Okay, it helps to calm them down. However, the NCLEX wants to know if you are aware that it can cause hepatotoxicity, or in other words, liver toxicity. Okay, because it's metabolized in the liver. So make sure that you know that valproic acid helps to treat seizures and manic phase bipolar, and it can cause hepatotoxicity. So these patients need to constantly have their liver functions monitored by their provider. Okay, so they need to do LFTs and see if their liver functions or their liver enzymes are elevated, because if it is, then that can cause damage to their liver. All right. And then lastly, PTSD. So PTSD, right, is post-traumatic stress disorder. And a lot of people are familiar with the term PTSD, but they really don't know what comes from PTSD. PTSD is a reaction to a very traumatic or catastrophic life event. And those situations can be life-threatening to the person and others if not treated and not dealt with. Okay. That's why it is such a major psychiatric health emergency, because these patients can lash out and hurt themselves or others from that traumatic event. All right. And it doesn't have to be war, right? Some people, just them having a baby and having such a horrible experience with that baby, like God forbid their baby died when they first were born and then they had to resuscitate them. That's traumatic. Or a child being abused as a child their whole life and growing up. That's traumatic. Or watching someone die in front of you. That's traumatic, right? So it doesn't have to be just war. Our soldiers that come back from war that experience PTSD. It can be from anything that was traumatic to that person. Okay, that it was just so traumatic that they are just they just couldn't deal with it. All right. So what are some of the symptoms of PTSD? One of them is reliving the event all over again. So this looks like intrusive memories, right? So they start to have, like, they'll just be sitting down and all of a sudden they have a flash of the memory and they just go into anxiety over it, right? Or they'll have recurring nightmares about the situation. And this is very common in our soldiers, right? Who come back from war, right? They start to have these recurring memories and nightmares. They have an increase in distress and they start to present physiological reactions. So things like increased heart rate, they'll have some kind of GI distress where they have diarrhea or vomiting or nausea. They get, they start to get these GI upset. And then they get very diaphoretic. They start sweating a lot, right? Because they're now becoming anxious from these experiences and these symptoms. So when that happens, your biggest thing is to decrease the stimuli, right? Bring them back to reality, all right? Don't let them stay in that memory, and tell them to breathe, all right? Tell them to breathe, tell them to calm down, and make sure that they are in a safe environment, that they're not going to harm someone, okay? So be very careful when you are around someone with PTSD, because they can lash out, reliving the memory of the situation, and they might mistake you for that experience and start, and possibly harm you, or they might harm themselves, all right? So they are at an increased risk of suicide. So this is why this is such a health emergency, and we need to address it immediately. Some other symptoms are, as I already said, anxiety, but also they start to detach themselves from others. They start to kind of be to themselves. This can also happen with rape victims, right? Or sexually abused victims, or sexually assaulted victims, right? Where they start to detach themselves from others. They start to stay away. They're more quiet than usual. They stay in their room. They don't want to be around people. They don't want to be bothered, right? So when that happens, something's going on, right? Something's going on. So you will see that with patients with PTSD. Also, they have an increased emotional feelings. So for example, right, they start to have insomnia, so they can't sleep, right? Especially because of that nightmare, or because of those intrusive memories, right? They get more irritable. They start having outbursts and lashing out in anger and rage over the situation. They're very jumpy. So like, you might like come up behind them and touch their shoulder, and they'll be like, and jump back, and like, they're just so jumpy, right? They have a decrease in concentration or focus. It's very hard for them to focus on something, because their mind is just racing from that experience. They're very hyper vigilant, so that you might see like someone who let's say, God forbid, was raped. They might start stocking up on pepper spray and knives and guns or whatever, or someone in war, they have a gun near them all the time, right? It's because of that experience, right? So some other things is that they start to avoid any reminders of the event, right? So they start to stay away from certain things that remind them of that event, right? So let's say, God forbid, someone got raped in a party or got abused, in a particular place. They'll avoid that place. They have thoughts, so sometimes they suppress the thought or repress the thought, right? Because they don't want to think about it. They avoid certain people. So like, let's say they were in a domestic violence situation. They'll avoid the person's family and friends, because they just don't want to be reminded of the event, right? They have they lack an interest in life and goals. And usually this is because they're depressed, right? And because they become so consumed with that experience. And then sometimes they actually experience amnesia of the event. So even living in, like, for example, I know that there's some people who lived through the Haiti earthquake back in 2010, and that experience was so traumatic that they can't recall those small details of the event, because that was how traumatic it was, right? So sometimes they just completely have amnesia over the event, and they just really just don't remember, and they think that nothing ever happened, right? So those are some things that happen. Those are some symptoms of PTSD. And the biggest thing is to decrease the stimuli, right? And also, so they need to go to counseling, right? And sometimes they might put them on some kind of anti-anxiety medication, or antidepressant, depending on what they're experiencing and what their symptoms are, so that they can be able to recover from that experience. So NCLEX is going to ask you these kinds of questions to see, do you know how to manage and what PTSD looks like, right? And again, these people are at increased risk of suicide, increased risk of hurting someone else, or hurting themselves. So they can pose a threat to themselves and others. So you want to make sure that you address it immediately, so that these patients don't end up hurting themselves or others. So guys, those are just some quick NCLEX psychiatric tips when you're answering those questions, so that you can have that quick knowledge to be able to answer the question, all right? Because these are some questions that I see a lot of my students that I'm tutoring, that they get tripped up on, right? The difference between a delusion and a hallucination, the difference between manic phase and the depressive phase in bipolar disorder. These are some things that you really want to make sure that you know. A lot of people don't know about delirium tremens. They just know that you can end up with a seizure and possibly die, right? But there's so much more to it. And NCLEX can ask you a lot of questions just based off of that, and they can rephrase the question. But as long as you know the basic foundational information, if you understand the concept and you can critically think, you'll be fine on the NCLEX. Just remember that you always want to decrease stimuli in your patients, and you always want to show reassurance when you're answering those questions. Always be the nurse that is reassuring them. The answer is never a why answer, right? So if the answer, one of the answers says why in it, throw it out. Okay, that is never the answer. Okay, why is never the answer. If you see a yes or no question or a very close-ended answer when you're reading your answer choices, and the question is more like, it's like you as a nurse is asking like a yes or no question, that's never the answer unless it's a suicide question, okay? So the only time that you need a yes or no question is if it's a patient who's suicidal. Are you feeling suicidal? Do you want to harm yourself or others? Those are the only times that you answer yes or no, right? And you pick that answer. But every other time, you reassure the patient, you provide safety, you don't challenge them, you bring them back into reality, and you develop that rapport with them. Okay, let me tell you, that is the number one thing in NCLEX. Okay, you always develop a rapport with your psychiatric patients on NCLEX. So any question that allows you as a nurse to develop a rapport or a trust relationship with the patient, you always want to do that. And lastly, anytime there's a question and the patient's manipulating you, right? Like there's a question about a patient that's manipulating you and they're saying, do you promise not to tell anybody if I tell you? You never say yes. You never promise a patient that you're going to keep the information confidential. Instead, you kind of go around them and you say things like, it seems like you have something important to tell me. You can trust me. You can trust me to tell me, but you never say, I promise I won't share the information. Never pick that as an answer. Okay. You don't ever want to make promises to your patients that you know that you can't keep, and you most likely will not keep, especially if it's going to harm someone or they're going to harm themselves. And then lastly, with suicide patients, always get them to sign a contract. Okay. Always get them to sign a contract stating that they're not going to hurt themselves or they're not going to kill themselves. Okay. You always want to get them to sign a contract. But before you get them to sign the contract, you first got to develop that relationship with them. You got to develop that trust with them. All right. So always look for the answers where you're developing trust or they're signing a contract, and you're also asking those yes or no questions. Do you want to harm yourself? Yes or no. Okay. Those are the only times that you ask close-ended questions with is in suicide situations or in situations where the person's having hallucinations and they're hearing voices and the voices are telling them to harm someone, okay, or themselves. All right, guys. So that's my quick NCLEX tips. Again, my name is Damaris. I am one of the tutors, CEO and co-owner of EdMe Nursing Tutoring. You can follow us on Instagram, which you're on right now, or you can follow us on YouTube at EdMe Nursing Tutoring. And it's ed-me Nursing Tutoring on YouTube. And then for Facebook, same thing, EdMe Nursing Tutoring. And again, you can reach us at edmetutoring.com, or you can email us at edmetutoring@gmail.com. Thank you guys so much for joining me. I hope this was informal and that this information will help you to be able to answer your questions on the NCLEX. So go ahead and do some practice questions on Psych questions and see if you get those questions right. Give me some feedback. Tell me if this information helped. All right, guys, thanks so much. Have a wonderful day and God bless you guys.